Right. So we were talking about regulation of insulin secretion by the beta cell. We have already talked about the nutrients, right? Glucose, amino acid, fatty acids, even rising level of ketones in the blood, all of them increase the secretion of insulin by the beta cell. Then we talked about the role of incretins, right? They also increase the release of insulin from the beta cell. Now we come to some other hormones, right? There are some other hormones other than the incretins, which can also influence the secretion of insulin. For example, we can talk about glucagon, right? Glucagon, and please I will remind you, glucagon is produced by the alpha cell, and it should not be confused with glucagon like peptide 1. Glucagon like peptide 1 is basically incretin coming from gastrointestinal system, right? It is a different molecule than glucagon. Now glucagon can also directly stimulate the beta cells, right? Its receptor increase intracellular cyclic AMP level. You must be knowing that glucagon receptors are 7-pass receptors, right, which are coupled inside with what? With G stimulatory proteins, and G stimulatory proteins activate adenylyl cyclase, right? And these adenylyl cyclase enzyme, right, when it is activated, again glucagon will bind with 7-pass receptor or G protein coupled receptor, and this will stimulate intracellular G stimulatory proteins, and these G stimulatory proteins will stimulate adenylyl cyclase, and adenylyl cyclase convert ATP into, yes, cyclic AMP. So basically this is the rising intracellular cyclic AMP level. It is the rising intracellular cyclic AMP level which also lead to what? Release of insulin, right? That also release of insulin. And remember that actually glucagon like peptide 1 and gastric inhibitory peptide, their receptors are also coupled through the G stimulatory protein to adenylyl cyclase, and they also lead to increase in intracellular cyclic AMP. Actually we must know all the factors which increase the level of cyclic AMP inside the beta cell, they lead to additional release of insulin, right? So I was telling you that glucagon can directly stimulate to the beta cell to produce extra insulin. And here I should mention the patient who have glucagonoma, is that right? Patient who have glucagonoma, it means these patients overstimulate the beta cell. And when they overstimulate the beta cells, over the long time, beta cell become exhausted, and eventually, initially insulin secretion is more, and when overstimulation lead to damage to the beta cell, then insulin production become less, and that can lead to diabetes. In the same way, some other hormones like growth hormone, right? You know, in patients with acromegaly, there is excess of growth hormone. And many patients with acromegaly also have diabetes. Why? Because number one, in acromegaly patients, growth hormone is very high. An elevated level of growth hormone, it produces more glucose in the body by gluconeogenesis, right? Growth hormone increases the gluconeogenesis, so glucose production by the liver is more, right? And blood level of glucose goes up, and growth hormone reduces the uptake of glucose by the peripheral tissue. Both conditions produce chronic hyperglycemia, which stimulate the beta cell to produce excessive amount of insulin. But remember, in the long run, beta cell will again become exhausted, and type 2 diabetes can set in. Another example of hormone is cortisol. Cortisol, if someone has Cushing syndrome, in patient with Cushing syndrome, there is chronic elevated level of cortisol in the blood, right? If in my blood cortisol levels are very high for a long time, what cortisol will do in glucose metabolism? It also increases gluconeogenesis, right? And decreases the glucose uptake by the peripheral tissues, result will be again chronic hyperglycemia, and that chronic hyperglycemia will initially overstimulate beta cell and produce more insulin, but eventually again beta cell will get exhausted and patient will develop type 2 diabetes mellitus. Am I clear? So what I'm saying that even though incretins are having a strong role in amplifying the glucose dependent release of insulin, along with that, glucagon or excessive growth hormone or excessive cortisol can also lead to excessive stimulation of beta cell and initially lead to excessive release of insulin, but eventually what happens, right? What happens? Beta cell get exhausted and insulin secretion drop. Am I clear? Now we come to another factor which regulates the release of insulin, that is the autonomic nervous system. Now, as you know, autonomic nervous system has two units. Autonomic nervous system has, yes, sympathetic nervous system and, yes, parasympathetic nervous system. Now, you must be knowing that parasympathetic nervous system is activated when you have taken food, right? But sympathetic nervous system is activated when there is some sort of crisis. Is that right? Now, first of all, we see the role of parasympathetic nervous system. When you are taking food, right, then vagus nerve is activated, and vagus nerve, right, parasympathetic nervous system is activated, and vagus nerve, via the vagus nerve, right, 10th cranial nerve, right, there is release of acetylcholine on the beta cell, and this acetylcholine basically stimulate, what is this? Cholinergic receptors on beta cell. Is that right? And that lead to increased release of insulin. So this basically stimulated and lead to increased release of insulin. Am I clear? Secondly, so of course again it is beneficial. Now look it is all coordinated. You take the food, first of all nutrient go and stimulate the release of insulin. Then from gastrointestinal system, incretins go and further amplify the release of insulin. Then of course when you have taken food, parasympathetic nervous system is stimulated and through the via the vagus that releases acetylcholine on the beta cell that further increases the release of insulin. But what about sympathetic nervous system? You know, sympathetic nervous system is stimulated under stressful circumstances, and you know, when there are stressful circumstances, we want less insulin. When there is stressful circumstances, we want less insulin. You know why? Because if insulin is less, then insulin mediated uptake and utilization of glucose by the peripheral liver, muscle and adipose tissue will be less, and glucose which is present in the blood, that will be having a better supply for central nervous system. Again, in stressful circumstances, actually we want insulin secretion to be inhibited, right? So under stressful circumstances, sympathetic nervous system, especially adrenergic, noradrenergic neurons release norepinephrine. Sympathetic nerve endings produce norepinephrine, and norepinephrine act on alpha-2 adrenergic receptor, and these alpha-2 adrenergic receptors are coupled with G inhibitory, and that actually inhibit the adenylyl cyclase. And when adenylyl cyclase is inhibited, what happens? There is ATP to cyclic AMP conversion is less. Again, what really happens? In stressful circumstances, nerve endings release norepinephrine on which cell? Beta cell. And norepinephrine act on the alpha-2 adrenergic receptors, which are coupled with G inhibitory, and stimulated G inhibitory inhibit the adenylyl cyclase, and intracellular cyclic AMP level go down, and falling cyclic AMP level reduce the secretion of insulin. Is that right? Am I clear? Now, what are these stressful circumstances? Many stressful circumstances. Maybe, for example, when a patient has fever, right? Or patient has shock, or yes, patient is undergoing surgery, right? Insulin secretion will be reduced, or patient has extensive infection, right? or patient has severe trauma. Now all these circumstances like fever, shock, and extensive infections, trauma, right, they produce so much biological stress and activate the noradrenergic system that while alpha 2 adrenergic receptor insulin secretion will be reduced. But remember one thing, that epinephrine which is coming from mainly from adrenal medulla, that can act on beta 2 adrenergic receptors. Beta 2 adrenergic receptor. Now it is a little focus is required. Norepinephrine dominantly work on alpha 2 adrenergic receptor, epinephrine work on beta 2 adrenergic receptor. Norepinephrine is mainly released by nerve endings and epinephrine is coming from adrenal medulla. Alpha 2 adrenergic receptor inhibit the cyclic AMP production, but beta 2 adrenergic receptor increase the cyclic AMP. Is that right? So it means if beta 2 receptors are stimulated, insulin will be more secreted. If alpha 2 adrenergic receptors are stimulated, insulin will be less secreted. Now, on the beta cell of islet of Langerhans or on the insulin producing cell, concentration of alpha 2 adrenergic receptor is more and beta 2 adrenergic receptor is less, because these inhibitory receptors are in higher concentration. So dominant effect of sympathetic nervous system is inhibition of release of insulin. Is that right? Now another thing, we talked about all these incretins which increase the release of insulin, but I should mention one hormone which specifically decreases the release of insulin. Do you know the name of that hormone which inhibits the release of insulin? I can give you a hint. That is a hormone which inhibits many other peptide hormones release. That hormone is a universal inhibitor of most of peptide hormones. Yes. What is the name of that hormone? That inhibitory hormone is, yes, somatostatin. Somatostatin, right, act on the beta cell and inhibit the release of insulin. But actually somatostatin inhibits the release of many peptide hormones. For example, somatostatin inhibits the release of insulin. It also inhibits the release of glucagon. It is produced by the delta cell of islet of pancreas. So somatostatin inhibits the release of insulin. It also inhibits the release of glucagon. Even it inhibits almost every hormone of GIT. For example, somatostatin can inhibit the release of glucagon like peptide 1, inhibit the release of GIP, inhibit the release of secretin, inhibit the release of cholecystokinin, inhibit the release of gastrin, inhibit the release of motilin, inhibit the release of vasoactive intestinal peptide. So basically it's a universal inhibitor of many peptide hormones. Even somatostatin inhibits the release of growth hormone. It inhibits the release of thyroid stimulating hormone. So when you have to remember somatostatin, just remember it is a universal inhibitor of most of peptide hormones. That's it. So not only it inhibits insulin, it inhibited many other hormones, right? So this was all about the factors which influence the beta cell, right, as long as insulin secretion is concerned. Now, what is the pattern of insulin stimulation? For example, if I take food, right, and you keep on measuring my blood level of insulin continuously, what is the pattern of insulin release? Actually, insulin release is biphasic. Let us suppose we are measuring, here is the time and here is the insulin concentration in blood. Actually, insulin release is biphasic. Biphasic means that as soon as you take the food, after about 3 minutes, insulin level very rapidly goes high in the blood. And insulin level after 3 minutes will start rising very rapidly, and about 5 minutes it will go to the peak. Then insulin level will gradually fall down, and then second peak will come, and then it will progressively, level will remain high until when glucose level goes down, it will come down. So we can say this biphasic, right, release of insulin. This initial release of insulin is after taking the food, because there was a lot of pre-formed, pre-stored insulin which is suddenly released. Once this bulk of insulin is released, right, pre-formed, pre-stored insulin is released, then what happens? There is increased synthesis of new insulin. Now in second phase of increased insulin release, here the preformed insulin is also being released and newly synthesized insulin is also being released, right? So this was all important factors related with insulin secretion. Before I really close, I want to mention that there is many type of insulin, right? Human type of insulin, and insulin, not now it is not available. In old times, few years back, we were also using insulin coming from the, bovine sources, and insulin coming from the pig, right? Now, let's suppose here is human insulin, and if you compare it with the pig insulin which is derived from the pig, we also call it porcine insulin, and compare it with the insulin from the cow, which is also called for bovine insulin, right? What is the difference in that? Actually, what do you think? Pig insulin is more like human insulin, or bovine insulin is more like human insulin?
Pig.
Oh, you know it. Yes, pig insulin is, porcine insulin is more like human insulin. The difference in human insulin and porcine insulin is only one amino acid. But difference in bovine insulin and human insulin is 3 amino acids. But now both of them are not being used therapeutically, right? Bovine insulin was taken out of US market long time before, when there was a risk of mad cow disease, and porcine insulin was taken out of, you can say, from the market, or it was not being produced anymore from 2005 onward, right? And human insulin and its modifications are available, that we will discuss in pharmacology of the pharmacological management of diabetic patients, right? Now, before really I finish this topic, I would like to talk about something which we forgot in the beginning. You remember we talked about the C peptide?
Yes.
Which was connecting the A and B peptide of the proinsulin, right? Let's talk few words about C peptide, right? So, C peptide, up to now we remember from our early lectures that C peptide was the connecting peptide between A and B peptide of the insulin, right? And we remember that C peptide was secreted by the, or released by the beta cell in equimolar amount with the insulin. Is that right? Let's suppose that here is your circulatory system, right? And here is your pancreas, and from the pancreas, from the beta cell, right? Not only insulin is released with A and B peptide, but there is also release of C peptide in equimolar amount to insulin. But remember one thing, insulin has a half-life of only 5 to 6 minutes, but C peptide has a longer half-life, up to 30 minutes. Why? Actually, insulin, once it is released from pancreas, it is released into portal circulation, and when insulin first time passes through the liver, about 50 to 60% of insulin is destroyed in the liver. Is that right? So, when insulin reaches from the, okay, I should improve this diagram. I will show portal circulation. Let's suppose this is pancreas, right? Here is your portal circulation coming from GIT, and it is passing through the liver, and then from the liver blood will eventually go to the where? Systemic circulation, right? Now remember, when beta cell produce insulin, right, via the portal circulation, when insulin is passing through the liver, 60% of insulin is destroyed during the first pass. Is that right? It means only a small portion of insulin goes to the systemic circulation. And even this small amount of insulin, right, which reaches systemic circulation, right, it is destroyed by insulinase enzyme in the liver and in the kidney mainly, right. What happens? The insulinase enzyme which is present in the liver and in the kidney, that break down the disulfide bond. You remember there was A peptide and there was B peptide and there was disulfide bond, right. These insulinase enzyme, right, insulinase enzyme break down these disulfide bridges. So A and B chains become separated. These separate chains are biologically inactive, and these separate chains, A and B chains, they filter from the glomeruli and eventually they appear into urine, A chain and B chain, right? They filter into urine. Now, C peptide is not destroyed as rapidly as insulin, right? So its half-life is long. This is one difference between insulin and C peptide. Secondly, another important factors which I would love to mention, that C peptide had its own importance, right? Previously, C peptide had only importance that it used to act as a marker for endogenous secretion of insulin. As I told you in my previous lecture, that C peptide is secreted in the same amount or equimolar amount with the insulin. Is that right?
Yes.
And C peptide is a very good marker of an endogenous insulin secretion, right? And if you really want to know how much insulin is being secreted in body, C peptide is a better marker than the insulin itself. Because if in the peripheral blood, if you take a blood sample and measure the insulin, you know the insulin which is present in systemic circulation, but you don't know exactly how much insulin was really produced and destroyed here. But if you measure the C peptide level, that will directly correlate with the endogenous secretion of insulin. Is that right?
Yes.
So C peptide work as a marker of, what is this? Beta cell function, right? And under these circumstances, C peptide levels in the blood can be a good indicator in certain situations. For example, in type 1 diabetes mellitus, most of the beta cells are destroyed. So endogenous insulin will be, secretion will be more or less in type 1 diabetes. Most of the beta cells are destroyed. So endogenous secretion of insulin will be less. So in these patients, blood level of C peptide will be less. So you can say importance of C peptide, number 1, in type 1 diabetes, C peptide levels are low. Now we come to type 2 diabetes. In type 2 diabetes, you know, there is peripheral resistance to the action of insulin, right? In type 2 diabetes, one of the major problem is that receptors on the peripheral tissues, right, insulin cannot produce enough action, right, and glucose cannot enter into peripheral tissues, and blood level of glucose is high. And this high level of glucose in type 2 diabetes stimulate the beta cell of pancreas to produce extra amount of insulin. Are you understanding? Now, in type 2, so it means in type 2 diabetes, beta cells are there, at least in the early part of the disease and middle part of the disease, right? During the early course and middle course of the disease in type 2 diabetes, beta cells are there, right? The problem is with the peripheral resistance to insulin action, and beta cells are even trying to produce extra amount of insulin, right? Now, in type 2 diabetes, endogenous insulin secretion may be normal or even slightly elevated. So what about the C peptide? So in type 2 diabetes, C peptide level in the blood will be low or high?
High.
They will be high. They will be normal or high. Then another situation. For example, if there is a patient who has severe hypoglycemia and you are confused that this hypoglycemia can be due to insulinoma. For example, there is a patient here and this patient is standing here and he has a very well developed insulinoma. It means a tumor which produces massive amount of unregulated, uncontrolled release of insulin. What will happen to C-peptide in this patient blood? Very, very high. So in patient with insulinoma, C-peptide levels will be very, very high. But sometimes we come across the people, they inject themselves with overdose of insulin. And if someone is injecting overdose of insulin, he will have hypoglycemic attack. In these patients, when you are giving exogenous insulin, remember, when we give exogenous insulin which is available in the market does not have C-peptide, right? When patient take exogenous insulin, then endogenous insulin release will be suppressed. So C-peptide in these patient blood will be low or high?
Low.
It will be low. So these people who are taking exogenous insulin, right, their C-peptide level will be low, especially in some fictitious situation, some paramedical staff or medical staff or someone to try to get some benefit from medical situations or insurance or somewhere, he or she may start injecting herself with the insulin to induce hypoglycemic attack. In these cases, C-peptide level will be low in the blood because this insulin is taken exogenously, it is not produced endogenously. Now, this was something about the blood levels of C-peptide. Now, another important thing. In previous years, we used to think that C-peptide is biologically not active. But now we are coming to know that C-peptide has also its biological actions, right? Especially C-peptide, two actions are very important to know about the C-peptide. Biological actions of C-peptide, number one is that it stimulates sodium, potassium, ATPases. And number two, C-peptide can stimulate the endothelial cell to have more nitric oxide synthetase enzyme. So it means endothelial cell under the influence of C-peptide have more endothelial nitric oxide synthase. So they will synthesize more nitric oxide and they will release more nitric oxide. And you know nitric oxide is vasodilator. So actually this endothelial production of nitric oxide under the influence of C-peptide, the small amount of nitric oxide keep the, what is this? It's very small micro vessels, blood flow regulation. Now it has clinical importance. You know what is that? Originally it was thought that patients of diabetes mellitus have only one problem, that their insulin level in the blood is less. So when exogenous insulin could be injected to the patients with diabetes mellitus, originally doctors thought all problem will be solved. But it was not true. Again, originally we thought that only problem in diabetic patient is deficiency of insulin. And we never actually, diabetic patient have deficiency of insulin as well as deficiency of C-peptide, especially type 1 diabetes. In type 1 diabetes, the deficiency of insulin as well as C-peptide. We used to think in the past that insulin deficiency is a big problem and C-peptide deficiency is no problem. So when we started giving the patient with type 1 diabetes exogenous insulin, we thought every problem will be solved, but it was not true. If type 1 diabetic patient is not given insulin at all, they will die due to diabetic ketoacidosis. But if you keep on giving them insulin regularly, you will keep them alive. But still, even if you replace the insulin very well, they used to develop some long-term complication. Long-term complication due to microangiopathy, due to pathology in small vessels, which will result in retinopathy, neuropathy and nephropathy. That very small vessels in retina will be develop pathologies, and blood vessels going to the nerves, they will be also become diseased, and that will when those micro vessels to the nerves will be diseased, that will result into neuropathy. And when microcirculatory vessels in the kidney will be damaged, that will produce nephropathy. So doctors discovered in type 1 diabetes mellitus, when there's, of course, there's deficiency of insulin, replacing the insulin will save the patient life. But still these patients developed in the long run some microvascular complications like retinopathy, neuropathy and nephropathy. Now it is discovered that this is the C-peptide. By activating the sodium potassium ATPases and by inducing the endothelial nitric oxide synthase, this maintains the health of what? Microvasculature and neuronal health, right? And can you believe it, now the drugs are coming, synthetic C-peptide, which will be given to the patient with, already some studies are done that synthetic C-peptides are in clinical studies are given to the patients with type 1 diabetes, and in these patients progression of retinopathy, neuropathy and nephropathy has reduced, or even neuropathy or nephropathy has improved. You are understanding? Patient got better. So now we can say that those days when we thought C-peptide is biologically inactive, those days have gone. Nature has made nothing useless. Even C-peptide has its own function, right? And future will be coming when that we are thinking not only we should replace the insulin in type 1 diabetes mellitus patients, but we have to replace the C-peptide also, right? Any question? No. Class dismissed.